I call the Healthcare Committee meeting today at 10 after 1. First, we're going to have the invocation by Councilor Curtis Snell.
Rise, please. Dear Heavenly Father, thank you, Lord, for this day. Thank you for the cool weather you provided for us. We ain't going to miss the 100 degrees, I don't think. But Lord Jesus, be with us as we go through the committee meetings today. Bless the visitors we have here. Bless the members that we have of the committees. And Lord, be with the council, and we pray for wisdom, pray for strength. And thank you, Lord, for everything. In Jesus' name we pray. Amen.
Amen.
Ms. Shelley, will you call the roll for us, please?
Janelle Fulbright,
Present.
Dick Lay,
Here.
Bill England,
Here.
Jack Baker,
Here.
Joe Bird,
I did.
Juliet Hubbs, Jody Fishinghawk,
Here.
Meredith Fraley, Don Garvin, Tyler Dory Jordan, Frankie Vargas,
Present.
Chuck Huskey Jr.,
Here.
Lee Keener,
I'm on me.
Curtis Snell,
Here.
David Thornton,
Present.
David Walkenstick, Eric Allen Watts. We do it with one.
Thank you. I assume everyone has had time to go over the minutes, and the chair will entertain a motion for approval of the minutes.
Second.
All in favor? Aye. All opposed, same sign. The minutes are approved. In reports, we'll go straight to the Claremore Service Unit with Mr. George Valyers.
He'll be here momentarily.
Okay, well, we'll just skip right on down to Cherokee Nation Health Services. Tommy Davis.
Good afternoon. I know that you've received the Health Committee packet, but I've also placed in front of each of you an update kind of to things that have happened since then that I thought might be helpful to you. The first thing I want to highlight is that our own Dr. Doug Nolan, the medical director for Hastings Hospital, has been recognized by the Oklahoma Rural Health Association as the Physician of the Year. And he'll be recognized at a dinner in Norman, Oklahoma next Friday. I think that speaks loads to his leadership ability, and is another thing that Cherokee Nation can highlight, that we have the Physician of the Year on our staff here.
Congratulations.
And also, August 31st, right before the holiday kicked off, Dr. Rubidoux, the area director for Indian Health Service, came and met with the leadership of the health department and the tribal leadership to discuss health issues. It was a very nice visit. She was very complimentary of our vision to become a little more financially independent and run health as a business so that we can provide more services to our patients. Our GEPRA scores, which measures quality and compares us to the other IHS facilities, far exceed any others. And there's a packet that's on your table that we shared with her during that visit, that our staff has done a great job highlighting those things, and so I thought you would enjoy having that same information available to you. An update on some recruitment of specialties. We are recruiting Dr. Gehring, a urologist, and as soon as he's finished his credentialing, he'll be doing an office day in the Muskogee Clinic. And our plans, like I've told you before, on all of the specialists that we're recruiting in, is that they will go out to the other communities and provide those specialty services in all of our clinics and not just be located here in Tahlequah. We're also recruiting Dr. Lutton, a neurologist. He comes from Muskogee. He's been here for years, or in the area for years. He will also be doing a clinic day in Muskogee as soon as credentialing is completed. And Dr. Reefer is an orthopedic surgeon that we're in the process of credentialing as well to help see the many orthopedic procedures that we take care of. We spend, I don't know, Brett, how much do we spend on orthopedic services every year? Well over $1 million. That's what I was thinking, but close to $2 million. So the more of those kinds of specialties we can handle here in-house, the better our patients can be seen more timely as well. I've attached an update on the Affordable Care Act for your review in your packet. And Jeff Sanders from the pharmacy that we all know and love sent a nice update that we can now, there's a prompter for the patients to push the pound sign after they give their birth date. I guess they were having some trouble with that. But the even better news is they can hit the number 8 and talk specifically to a staff member. So that's great news. And I learned at my Muskogee visit this past week, they fill over 5,000 prescriptions a day. And that's just a huge load, and it's growing by the week. So they're doing a good service over there, and I know you've got lots of complaints about the audio care, and I think the sooner we get this, there's some phone system logistics that have to be worked out with some of the other clinics, and very soon this will be a smooth system, I hope, for all of our patients. But we're also working on a policy that will allow patients to make an application that we will call them if they're having difficulty with this new system and fill their prescriptions. And I hope to have that ready to present to you guys for consideration next month. And what else here? Contract health, one of the things we're doing there, we've moved to a model to approve contract health referrals on a daily basis, especially the cardiac and cancer patients. And we've decreased the waiting time from 10 days for appointments down to 2 days. So that's a good thing. And just another note, the Bonita Health Clinic, we were scheduled a grand opening for September 25th, but we were having some difficulties coordinating everybody's schedule that we wanted to be able to attend, and that's now been moved to October 23rd. So I apologize for the inconvenience, but we want to make sure everyone that needs to be represented has the opportunity to make that grand opening. Right before this meeting, I signed the contract to begin the remediation at Redbird Smith, and they're hoping to begin the aggressive remediation of that clinic on Wednesday. At Wilma P, we've met with some architects, and we're trying to coordinate our schedule to go over there and let them look at our building and the land that we have. And they've estimated they can do an expansion of the 12,000 square feet for about 2/3 of the cost we were initially thinking. So I'm really excited about that opportunity, and I'll let anyone who wants to go with this that. Yeah.
Could you get a hold of us and send an email, because I'd like to be on.
Yes, absolutely.
Because I talked to constituents, they don't want nothing like Three Rivers, they don't want nothing like Bonita. They want usable space, they don't want it wasted
So
on
do
an
we.
atrium or anything else.
We absolutely agree.
Okay,
We agree. You bet.
bet.
Sam Hyder, we were notified last week that we may have actually found land there close to the food distribution center. Bruce Davis is helping us with that, and I'll keep you updated on that as well.
That's another one we could let us know, because I was up there talking to them, but they said the same thing, they want usable space.
Right, right.
Okay.
All right. And we met with Three Rivers staff as well as the Bartlesville staff last week and had very good visits with them. Bartlesville Clinic runs incredibly well. They see well over 20 patients per provider a day, and we think that the model that they use, we can use in our other clinics. Space is always an issue everywhere we go, but they have an incredibly positive attitude, and I really enjoyed the visit up there. And the magnetic doors have finally been installed at Salina. That's something that that district has worked on for some time, and so we're glad to have that. And the Nowata Clinic, 12-hour clinic days are working really well. We're seeing more and more patients up there, and we get comments all the time at how glad they are that they're happy there's access after work hours.
Are you going to do the 12-hour days elsewhere?
We are doing a trial basis in Stillwell and Muskogee right now. Of course, it'll require additional staff, and so, yes, we're looking to see what all we'll need to support those efforts in those clinics.
Councilman Hoskins next.
Thank you. Connie, when will we be fully staffed at Bonita? All of the programs that we hope to operate out of there, when will they all be operational?
Well, I hope they are as close to that point right now as possible. I need to get a report from Elton this week. He's covered up, as you can imagine. But I believe we should be fully operational.
Okay. Including the dental and all of those things?
Don't hold me to that today, but as far as I know, we've got everything going that should be.
And Council Fishing Hop, we're going to use every bit of that space at Bonita. We're going to find ways to use it. So The atriums are nice. Thank you. Thank you.
Created a job for a window washer for sure.
Counselor Carrick Watts is next.
The first I heard about, that I recalled hearing about the extended clinic hours was in the newspaper. So could you tell me more about the budgetary impact and our staffing impacts and such?
I think I had mentioned it at a previous meeting, but we had asked back in March when I meet with the medical directors and the administrative staff to see how we can improve access by extending the clinic hours, because the working person traditionally works the hours that we're operating the clinic. And the first 3 days that we were open there, they saw, I believe, 91 patients and opened up 36 new charts. So, and that's good because probably those patients have third-party resources that we can bill and collect, and that helps us pay for more providers and space.
Were there news releases sent out other than maybe I missed it that would inform the patients if there was these additional hours, or how did you inform the patient?
I would have to talk to Dr. Stallcup, but he had a huge impact. We were shocked at the number of people that showed up the first 3 days.
Yeah, I mean, it's great. I'm fully in support of it. I just want to be better informed so we can help answer constituent questions and encourage it
Okay.
if we're going to have the service available. Because a lot of our folks, because of the situation with Cumberland Indian Hospital being IHS and limited, are going to go to our other facilities, and so the people from our area will drive if they do.
Yeah, and we'll be happy to take care of them. That's part of the intent because we know access is an issue.
Okay, so you're able to do that with existing staff and existing
But
budgets?
they have been they've worked very hard and they are working extra hours, and we're looking at adding staff to make sure we can accommodate the workload. I mean, obviously, if you're open more hours, you're going to need more staff.
Will this affect our recruiting in the idea that, I know before we could recruit and say, for example, with clinic settings primarily, now we do have Hastings Hospital, which is 24/7, that your quality of life issue, that people, regardless of the money attraction, or wherever the salary threshold and benefits, but want to impact our recruiting and ability to recruit possibly?
Well, it will. I mean, we'll obviously have to recruit more people, but when we met with the staff in Bartlesville, they were very excited about it. They saw the need, or that it would meet. But a lot of people like the 12-hour work hours. And so they were discussing during our meeting ways that they could do that model there and provide the same service and not, decrease the number of providers during the day. So just in a preliminary discussions there, if the 2 providers there worked their schedules, we'd probably need 1 more additional provider to work like a Monday through Friday model.
Okay, thank you. So also, there was a decision in budget hearings about moving $1 million from, I think, discretionary funds and for Marcoma, which would come under your prevention, I think, and take it from IHS dollars. Do we have an analysis of what, that we did that action, but I don't think we understood maybe what the impact would be on taking from direct services for patients or our 638 agreements with IHS. Can you elaborate on what the impact might be on that?
I can some, and one of the many documents that I've piled up in front of you is Lisa Pivick and some staff, Vicki Hamby from Government Relations, have done that analysis and can help me speak to that impact if you would like.
I would love to hear more about this because we have, of course, the budget in front of us tonight. So.
Is it on the agenda? I didn't know if this was the proper place to talk about it.
Yeah.
We can go ahead.
Is it this one that's the Male Seminary Recreation
Yes,
Center
ma'am.
funding?
Yes, ma'am.
Yeah, so I have the floor and I'm asking about it. So
Okay. No, okay, I'm sorry.
'Cause I just got this, I haven't seen it beforehand.
Right.
I'd like to hear more about it.
What we're finding is that if we move it under the IHS compact, then we will be obligated to serve all Native Americans without charging them. Currently, if you're not Cherokee, we charge $20 to be enrolled into the gym for those facilities. And it will have a total impact to the budget of about $95,000 loss of revenue if we move it there. The other thing is, if we move it under there, we have to ensure that access isn't denied to anybody who is eligible. And we already know that the gym is overwhelmed, and we would have a difficult time ensuring that we can meet that standard. IHS would require feasibility studies, and we would require more staff to do the proper reporting to IHS. So we're concerned about that move. Lisa?
And just as a reminder, that's $1 million, right, that was in question for operating dollars around Marcoma? I believe it's $800,000.
Yeah, just under 900,000.
Okay. That answers my question.
Okay, good. Sure.
Thank you. Madam Chair, thank you for your time.
Councilor Baker is next.
Thank you, Madam Chair. I was looking at the budget, during our budget hearings, we had $800,000 that was allocated to dental and eyeglasses, dentures and eyeglasses, and about 600 and some thousand that's projected to be spent. Right now, that's limited to people, Cherokee citizens living within the 14 county jurisdictional area. Could you look into what it would cost possibly to expand that to include all Cherokee citizens coming to our clinics for those two items?
Yes, I'd be happy to.
Because we have a large number in Muskogee and Tulsa as well as Fort Smith that use our clinics but are denied access to those coverages. Maybe report back next month. Okay. Appreciate it. Thank you, Madam Chair.
Councilor Jordan, you're next.
Connie, adult walk-in at Hastings, is there some way that we can ask them to start answering the telephone?
Yes.
I mean, I know that's a small problem, but my folks here are telling me that they call and you have to,
Navigate through an answering service.
well, no, there's no navigation. You leave your message and you may get a call back and you may not. And if you get a call, they're only going to call you once. So if you stepped outside, you're just out of luck. It would appear to me, because I use adult walk-in, that there are ladies back there that could answer the telephone and take real messages and get some things taken care of. Or you'll call early in the morning and leave a message and you might get one that night. Well, that doesn't help much if you needed it answered between the, yeah.
I understand. But yes, we can absolutely look at that.
Now, some departments up there answer their phones, so I didn't know what the deal was with adult walk-in. Is there something that we're missing?
No, I think it's just a model that they've become accustomed to, and we can change that.
I would request that all departments actually answer their telephones.
I don't like an automated answering service either, so.
If you could. I mean, I thought, well, maybe I'm missing something. Maybe there's not enough people. But there really is enough people to answer the telephone. I've been standing there when,
There's people.
yeah, and it was, the telephone was going somewhere else, and I kind of wondered, well, why didn't somebody pick that telephone up? I would appreciate it if you'd look into it.
Absolutely.
Might check as a secret deal next month to see what they've done.
Well, we'll do that.
And I do appreciate Jeff. Now we can get through to a person. And they're very prompt about taking care of whatever the question is.
Okay, Councilor Thornton, you're next.
Yes, only thing I need to ask Ms. Davis is that how many prescriptions a day can our machine at Three Rivers, how many prescriptions can they fill out?
How many can they fill?
Yeah.
I'll have to defer to Jeff. How many prescription a day in the refill center at Muskogee?
We actually, when I designed that, right now it's capable of filling 5,000 per 8-hour shift, and it has 2 blank cabinets that it can increase our capacity to 10,000. That's per 8-hour shift.
Okay, thank you very much.
Councilor Coates, you're next.
Yeah, I wanted to go back to the questions about the Marcoma Gym, the Mill Seminary Recreation Center, and I know that when we opened that, we contributed greatly to putting a couple of other businesses out of business here in Tahlequah. And with the overflow, as you're putting it, that it is a very successful endeavor, and it's become quite crowded as a result of it. And I know that there are people that go to other businesses now, to other gymnasiums, the couple that are left in town, precisely because of the overflow of Marcoma. And I just wondered if we have ever explored the possibility of entering into sort of contracts or arrangements with other businesses here in town to pick up some of that overflow. Basically at the same rates or very similar rates.
I'm glad you asked that question and brought that up. I've asked Lisa Pivick, the director over that very successful program, to maybe talk to NSU, because at one time they were interested in adding another recreation area here in the community, and I think a partnership would be a fabulous way to meet the need. So yes.
So is that something with already existing businesses, or the development of something else?
It would be something
new rather than...
Yes.
Okay. Is there a relative, is there going to be kind of a plan about the expense involved in that, if that would be a less expensive or more expensive way to go than simply to make
we would have to do that.
Yeah,
we would have to do that.
Engaging in something like that.
Yes, ma'am, absolutely.
Okay.
We'll keep you updated though.
Very good, thank you.
Councilor Watts?
Thank you, Madam Chair. Back on the dentures and eyeglasses and even hearing aids, I've had some complaints within the Claremore Indian Hospital that we don't, even though that should be available to our area, we really aren't getting served our Cherokees. So can you give me a next month, or actually in a week or two before the next meeting?
Get an update, yes.
An update on how many, like maybe by county or how you want to do it, a analysis of who's getting what under that program, and that way they'll answer these questions.
Sure.
Thank you very much, Connie.
Councilor Byrd?
A couple of questions. One, back to Speaker Jordan on the phone call. Has that always taken place? Has this just started about not answering the phone?
Well, I believe it's an automated system. Correct me if I'm wrong.
So we've had
been
that
in
automated
place
system for.
Well, when I worked the clinic in excess of 10 years ago, they had an automated system.
Okay, this is not something we just.
No.
Go ahead.
It has always been an automated system, Connie, but some departments you can hit the button and you get a live person, like, for example, in Jeff's department. But for some reason, I've just noticed the last couple of years we've been having increasing requests for adult walk-in to answer their phone. Radiology, I think, answers their phone. There are several departments that answers their phone. But the only one I'm persistently hearing as a situation is adult walk-in.
Okay. We'll look into that and follow up with you right away.
I know we've always had an automated system, but there was always a method you could many times circumvent and get to a direct to a human.
Right.
But that's not an option with the adult walk-in.
Okay.
Mark Coleman. I support that place wholeheartedly. If we need to expand, I support that as well. I think we've got approximately 9,000 members. Usually about 25% are non-tribal members. We have a small percent that are Native American outside that are not Cherokees. So it's really a good PR thing for us with the community of Tahlequah. A lot of northeastern people come there, a lot of elderly that are rehabilitating go there. So if we're talking about expanding that some capacity, I wholeheartedly support that. And back to business, I don't think you guys went into it trying to put anybody out of business, but when the people downtown in Tahlequah, I don't think they look at Cherokee Nation and see if we're going to put in a business where they put one up. It's just open market out there.
Right. It was an incredible opportunity for the Cherokees, and it's nothing but great because I use the facilities and it's full all the time, all hours of the day and the evening.
It's a good place.
It is.
The more we stand there, like I said, the less we'll stand to these clinics.
That's right.
Thank you, Connie.
Councilor Hargis?
I had a question. On hearing aids, is it a policy that we provide one or we provide two? Because
I'm sorry.
On the hearing aids?
How appropriate.
You might want to check out. No, do we only provide one per patient or do?
That's the policy bit.
And
Those are things we need to look at, is some of the policies that we abide by restrict us, and so I think we can look at those as ways to change the policy and meet more need.
yes, I think we need to look at that. And I had another question. On the Cherokee Health Partners, what is the role of those from Tahlequah City? I've had a couple complaints that, the people have been from the Tahlequah City are coming in radiology and pharmacy, and that they're bossing our staff around. Do they have that authority?
Pharmacy? I'm not aware of that, but if you have a specific incident, I'd be happy to address it. But the Cherokee Health Partners is owned 51% by Cherokee Nation, 49% by Tahlequah City. Debbie Travis is the director over the radiology services. So the employment agreement is through Tahlequah City, but she is 51% our employee.
Is she? Oh, she's 51% our employee.
Yes.
So she has authority
Yes.
in our radiology.
Yes.
Okay. Is that the same situation in our pharmacy departments? Do we
I
have
don't know
somebody
anything
from
about
the?
pharmacy. I don't know why Tahlequah City would be in any part of our pharmacy right now. I'm a little baffled by that.
Okay.
You
They're
don't
not
know?
that I'm aware of.
I'll talk to you. Yeah.
Okay,
Okay.
yes, please do.
I think I may have an idea what the I'm not talking yet.
Counselor Lay, you're next.
Thank you, Madam Chair. Ms. Davis, the Bartlesville Health Clinic, you're going to expand it soon. I see in your flyer here. We talked about this the other day. I want to get this on record that a permanent building needs to be, a feasibility study needs to be done for permanent building, permanent clinic at Bartlesville.
We're doing a feasibility study for all clinics, all areas that we serve, and to see where we need to go.
For those who don't know, they operate out of a strip mall. And they just keep knocking walls down, going to the next office whenever they need space. And that's a good crew up there, they do a good job.
They are great.
And so I want to get that on record before you start spending $100 million in Tahlequah. I think we need to look at some of our clinic needs. We're a clinic-based system. We always have been. If we're going to change that now, we all need to know that we're changing.
Absolutely.
The other thing is, we seem to be fully staffing and high prioritizing Bonita at the expense of Nowata. We seem to be sending a lot of people to Nowata and from Nowata to Bonita without first backfilling their jobs.
We are waiting on panels from HR to fill those positions.
Well, why don't we wait until your panels get ready and then send them to them?
Well, if it causes a disruption in patients being seen.
It is causing a disruption. That's my point. That's why I mentioned it. And the 90-day prescription. Has anybody fixed that yet?
We reported on that last month.
And you were asked to report on it again. So I guess
No, it
nothing
would be a
else has been done.
$65 million impact to the budget over 5 years.
You know, I just can't believe that. Walgreens does it for our employees. Why can't we do it?
We're full profit. We're not. I know there's been some work done, and Sean, I don't want to jump out.
No, please do.
We have been in health insurance for a while. The doctors have done this out here. I know there's been some work done, and
Jeff, would you come up to the front? We
Sure.
can't hear you back here.
I'm sorry. I know there's been some work done, and I think it's a very plausible solution to what we all would like to see I know in reference to you, it's for 90 days. And I think it's going to be between maybe Connie and Dr. Montgomery and us to get that completed. I think it's to the point of completion. We'll probably just fine tune it to present if that's where we want to go with it. As Connie stated, over a 5-year period, it's a pretty high financial impact to Cherokee Nation. And I'll be honest, once again, I think I've talked to you in two separate meetings too.
3 or 4, and I'm targeting elders. I'm not targeting myself.
Okay, and that
younger people.
Okay, and I actually broke it down. Be going. I actually broke it down by age ranges, kind of like you had requested before, from 50 and up. And each one of those age ranges, if we were to do it carte blanche, would have a value associated with that. And I think maybe that's the information that needs to be presented to you before we really make some final decisions. Once again, I think it's really financially irresponsible to do things carte blanche based on an age range. And I do agree there is need. We have patients that do need some further assistance. But I think we have a really good plan in place to maybe take care of some of those patients.
Well, we're talking about the phone system here. Some folks can't operate that phone system.
Agreed. Yep. And now they can, if they can punch 0 or call directly to the pharmacy as they've done before, that's an option for them at this point, which is, a help in that direction for them.
That'll help.
Absolutely. And, once again, even those patients who can't operate the phone system, as I stated several meetings back, I think they need further assessment.
I think you're correct. And if we had some home health nurses in Nowata, they could go out and do that.
You're absolutely right.
Yeah. Any more questions? I'll be glad to answer them while I'm up here.
Thank you, Madam Chair.
Okay. Thank you.
Next is Tom Laura Jordan.
About 4 years ago, Connie, and this was before you came on, and this was when Brad Carson was over C&D, I asked him to do a study for the possibility of C&D funding a eyeglass, hearing aid, denture type business so that we could better serve our folks. And then even maybe if it was set up correctly using 8 days, that we might be able to branch out and cover the cost of serving our folks by serving others. And they did that study. I don't know where it's at now. At that time, they were not interested in doing it because they said, well, we're basically only going to about break even. Well, my argument was, if you break even, that's great because we're saving a lot of money by serving our own people, and we can serve them quicker. Plus, we can train our young people to do those types of jobs. I would ask you, if you would, to revisit that issue with the CMB board to see if there's a possibility that at this time with the new board, that they might look at funding those 3 areas by buying an existing business or setting up a business and getting with career services and having career services send some people that maybe we could train. None of these things are rocket scientist businesses, I understand. I mean, you don't have to have a doctorate in a field to do this type of work. I mean, my gosh, you can go over to the mall and in an hour they can make you eyeglasses. I think we can do it. I think we're plenty smart enough to do all 3 of these areas. We're spending a whole lot of money to do these very same things. And I wonder if it's not time for us now to move into this area where we take care of our own people, set the business up right so that we can maybe get some government contracts, cover other tribes, maybe do some work with Indian Health Service. And if we break even, that's great. If we lose a little, that's great. Because not great, but it wouldn't be so bad because we're providing a service to our people. So if you would you explore that with CMD and see if that's a possibility?
Yes, I will. That would go along with Dr. Jones is actually looking at making our own dentures. And that would be another way to, save us some contract health dollars, create some jobs, and, expedite the service that we need to our patients. So.
Well, there was a study done about 4 years ago.
Okay.
It just wasn't going to make a home run for them, so they weren't interested in it. But I think what it does for our people in delivering the service from ourselves to them, possibly quicker and at a more, a better price range, that I think it merits now being, we need to review it again.
Okay, that's good to hear.
The other thing that, I guess this is a takeoff of Dick's questions, could we not negotiate with our insurance companies on the 90-day, the 90-day bills?
No.
We have insurance.
Yes.
I can go to the drugstore and get a 90-day supply of medicines that you can't give me, but I can only get a 30-day supply from you all. Now, I know if they can get 90 days, there must be some way that we can get 90 days through our area.
I have actually tried that in the past, and because of our population size, we're basically told we're not big enough. And, insurances are really third-party administrators for employers, and it's up to the employers to choose the parameters of those plans. Even Todd Embry, when I had a talk with Chief Baker at one point, was going to look into that himself to see if there's something he could do. But I have met dead ends at all venues in the past of attempting to negotiate 90 days. And the first time I did it, I could show them that financially I was going to save the insurance company money. Because every time that they pay us for a prescription, they have to pay us a dispensing fee associated with that prescription. And so we could eliminate 2 dispensing fees, and the discount percentage on the medications that they had to pay us, in reimbursement, was saving them money as well. But that still did not make a difference even to an insurance company, which absolutely surprised me. And so that's, once again, it was no avail. Everything I attempted for us negotiating 90 days was unsuccessful.
So what I think you're saying, Jeff, is that when we renegotiate our insurance, the government side, when it renegotiates its insurance, it should include a 90-day supply on pharmaceuticals.
Are you talking specifically for Cherokee Nation employees?
Well, I'm talking, you said something about negotiating our insurance.
Now, our specific health insurance, we should have 90 days supply now. But for our patients and their private insurers, that's what I was going to reference to, is our collection and reimbursements. Because that's where I've had no success.
So if you have Blue Cross Blue Shield, which is what this government has and what CMB has, and probably what a great amount of private insurance folks have that go to our facilities, you're saying that they're saying we're not big enough?
No, I'm sorry. No, that was specifically to patients and their private insurance. As far as our own Blue Cross and Blue Shield, I have never spoken to anyone about our 90-day requirements.
Well, but back to the private, for example, my son walks into Hastings Hospital and needs medicine, and he has insurance. And you're saying that they will only approve him for 30 days? And there was, let's say they're Blue Cross Blue Shield. I'm kind of like Dick. I guess I can't comprehend that.
Yeah, it's a complex
It's okay for the drugstore on the corner, but we're not good enough for it?
They can negotiate their own terms as well. But once again, most of them are part of huge buying groups or insurance groups. And the employers, as I stated earlier, they're the ones that actually set what they're willing to pay in insurance benefits to the third-party administrators like Blue Cross and Blue Shield.
Well, I get really aggravated because it's almost like they want you to die before you get the next 30 days. In the hopes that they can save that last 30 days. I think that we need to work on this a little bit harder. There's got to be a way. if I can go down here to the drugstore, I can go down here to Reasor's. Reasor's is not that, they're not Walgreens and they're not Walmart, but if Reasor's can do it, why can't we do it?
Well, that's, once again, it's within our negotiations of those contracts and the Indian Health Service. You know, I can.
Well, somebody's doing a lousy job of negotiating. And I don't know where we need to go to try to correct it, but I'm in agreement with Mr. Lay here. We need to fix this. Our people should get 90 days instead of having to come back and use 2 more tanks of gas to come back and get those other 2 30-day supplies, because it's routine. You're giving us a 90-day prescription, but we can't get it except 30 days at a time. And of course, I'm the biggest offender. Somebody sitting next to you that knows I'm the biggest offender. I run plumb out. And then I think, oh man, I got to have that blood pressure medicine. They told me I'd stroke out if I don't keep taking that. Of course, some folks would probably like to see that happen, but folks, I am pretty good about taking that medicine, so it's not going to happen with that medicine. But it would be so much handier if we could get the 90-day supply. I mean, it's not like I haven't been on the medicine for 15 years. It's not likely that I'm ever going to go off until I do die. So let's figure out who needs to negotiate what, and let's get it done. You're a very intelligent person, and I think you can do it. I'm going to put it on your plate that we need to solve this problem.
I'll see if I can find someone more charming than Jared.
We have talked around this issue ever since I started on the council, and we're 5 years now, and Mr. Thornton's nodding his head. It's been a lot longer that Mr. Thornton's been on the council, and this has been an issue for our people forever. We need to solve it. We really do. If we don't do anything else, let's get that solved. And I think we can.
You know, the thing you need to keep in mind too is if we get it approved for those that have insurance, we still need to be equitable to those that don't. You know, and so there's, once again, you know, what do we really wish to accomplish?
Well, maybe we need to think about buying our drugs somewhere else.
I don't think we can get them any cheaper than where we get them now.
We can look at that. We can look at that.
Absolutely. We can review the process and the contract.
Seems like the kind of money we spend on drugs, somebody out there is going to listen to us about 90 days. I mean, that's not little money that we're talking about that goes into buying drugs for our people that we dispense out through our clinic system and through our hospital. I just really believe we can solve this, and we need to do it within the next year. I mean, you guys need to really, really work hard on this issue. We have a lot of elderly clients that they just can't. Either we're going to have to take the medicine to them, which I know that's something that we've talked about, dispersing people out to their homes to take them the extra 30 days so that they don't have to come in, but that's going to be really expensive. And you've got multiple hands taking care of medicine, and sometimes what you start with don't always get there like it should. You can ask the PACE center that. You go and you're half a dozen pills short or something. We don't want that happening. Thank you all for what you're trying to do and what you're going to do within the next year.
Yes, ma'am.
Councilor Anglin, you're next.
The property.
Keeping that in operation.
How much do we spend on the property? Just keeping it up, the maintenance?
Well, that's base cost. So the total cost of the is about $850,000. And that includes base cost, which is the maintenance, facilities,
That's total.
total
That's all I had.
Councilor Byrd, you're next.
back to our pharmacists here. Do we still get a lot of our pharmaceuticals from Ada? At one time, the warehouse was in Ada. Do we still work with them? Is that just IHS?
Not very much. I mean, we still go through Indian Health Service, but drug drag and purchase through McKesson wholesale. We still buy them at Federal Supply Schedule price. Yes.
So is that still IHS there?
It is.
Okay. So Claremore and Hastings, we still go through Ada.
Well, yeah, but the drugs are actually purchased through McKesson in Oklahoma City, but the billing and things do still go through that.
Okay. It wouldn't help if we had our own warehouse in this area.
You know, the advantage of us purchasing in large volume, we could save in some generics probably, and I've actually even looked into that, and I have two wholesalers. One of them is in Pryor.
Okay.
They can get a certain generics, but the problem is some of those generics aren't covered by third parties. So for the most part, I don't know that the staffing, the building, the storage would equate to savings versus the way we do the wholesaler.
You know what you might do for the sake of this discussion that we've had is why not give you 60, 90 days and just give us some options. What might fit the tribe. I don't know if you've already done that in the past year or so, but maybe we could take a look at some options that you would recommend, since that's your expertise. Okay?
Sure.
All right. Thank you, sir.
Okay, Councilor Watts.
Thank you, Madam Chair. I know that, I guess my perception of some of our staffing issues is that we also, with our networks of constituents, have a responsibility to help your staff and bring your Cherokee talent home in respect to that. I know even my husband's paid attention, and when he was out Rosebank, found a pharmacist for Benita, and they were extremely responsive and got on it, and he had a phone call within a week or two, and we have a Cherokee citizen that's now got to come home. But I think we still need to be Choctaws, but I'm okay with that. Yeah, at least he's Cherokee. So, I really do appreciate that. Now on the prescription stuff, we've gone to a automated, like, can they ask for if it's maybe birth control that they know they need for a full year or 6 months? Does it not automatically, don't we have a mail prescription and stuff, mail order prescription, so it's somewhat automated that they don't have to come in for that, or how does that work now? It seems like we've provided other solutions, and if I've had to discuss things with private insurance, that if there's a medical reason that prescription needs to be longer than a month, then sometimes that doctor can write the prescription to address some of these, because what I'm hearing from our body, or some of our body, is that it's not for everyone. It's only for a few that it's needed. So could maybe we resolve that at the doctor level and how the script is written? Would that resolve even the billing issues with the private pharmacist, the private insurance? Or I'm wondering if there's another way to approach this, because I hear a lot of frustration, but I know our staff work really hard on this.
I appreciate those comments, and I agree, we're not talking about everybody in 90 days. We're talking about the elders who are having difficulty navigating our process and getting in to get those. And so if we identify those, and I think they've got a policy to propose that we say, this is Miss Davis out in, whatever community, she's having this kind of difficulty, and that we evaluate them on an individual basis rather than say everybody in Cherokee Nation can get the 90-day refill. Another thing that we haven't discussed is a lot of our patients, they're so sick, they need to be monitored by a physician before we just automatically refill their medications every 90 days or even every 30 days. And I'm subject to that because I'm insulin-dependent diabetic, and, if I wasn't as educated about my disease, it would be dangerous for me to try to monitor my own blood sugars and make those adjustments without a professional, a physician, giving me guidance.
May I ask you, so is that an opportunity maybe for more engagement? Because I'm also concerned from when I listen to what they're saying, maybe about individual patients or coming back to them with our frustrations. Is that chance for an opportunity for us as a healthcare system to provide interdisciplinary care and maybe utilize those public health nurses in a different way, because it sounds like they need additional care. And that's a missing opportunity. That the issue around the prescription link is really a bigger symptom of a bigger problem and a missed opportunity. So maybe we can resolve that.
No, I would like to see that, and using the home health nurses, as Mr. Lay has suggested, is a great way to do that, and public health as well. So we'll get back to that. We don't want to say no. Keep that in mind. We don't want to say no to that. We're working within the confines that we're dealt. Maybe we need to be more creative or find a way to say yes rather than no to the 90-day. We're missing an opportunity somewhere.
So just to make sure, because I heard a comment earlier that, not from you, but from somebody on the body, that maybe Claremore is an Indian Health Service. We have no impact on IHS other than trying to influence them through the advisory board. So how will our citizens be helped in Rogers and Tulsa County, where it's all Claremore Indian Hospital service jurisdiction? Will we be able to provide that same, we need to also respond to them on these same issues. And I think, depending on what's going on, other counties are impacted also by that same circumstances. So when you're finally ready for a recommendation, will you make it in the form of a news release or a handout that we can give to our elders or those in medical needs so that they also know how to access those same services?
Yes, yes.
Okay.
And that's a good point, because we don't have control on that issue.
Thank you very much, Connie, and thank you to your team that worked so hard on this. Thank you.
Next is Councilor Fishing Hawk.
How did we used to do the 90 days for our citizens? I'm not talking insurance, not talking employees, just our citizens.
I'll have to defer to him as well, because I wasn't here.
In the past, Jody, there really wasn't the focus on, I think, collections either. And they came in, basically the appointments were every 3 months, so they got their 3 months of medications and left the clinics. When I first started here, there was a huge amount of waste, because they'd come in 2 months and they get 90 days, they come back in a month, they get 90 days. And before long, they had huge piles of medicines that the doctor changed 3 times over sitting in the house. And there's danger associated with that as well. So inherently, the smaller day supply, I think, is safer for patients for one thing. It can be an inconvenience from time to time, but with mail order, that was another thing that was put into place to really help with that as well. To kind of get those patients an easy access to their medications and not be without. But in the past, we typically went from appointment to appointment, filling those prescriptions following.
Okay, if it's a maintenance medication, once you get with the doctor and you start on your maintenance medication, they get it down. How often do we change after that?
It varies from when their appointment times are. They can come in and their blood pressure may be out of whack if it's a blood pressure medication, for example. And so it may not be working, or they may not be taking it properly. So there could be an adjustment in dosage, or there could be a change in medication. They could take it home. And even when we did 90 days, new orders were 30 days. That way, if they didn't have a problem, it wasn't a huge waste of medication. But they typically get changed by the provider based on the patients in their hospital.
Okay, like blood pressure medicine. I'm still not getting this, Jeff, and help me out here, because I'm not being mean to argue with you. But let's say it is blood pressure medicine. Let's say, take Toddy, for instance. They switch her around 2 or 3 times and get her on what she needs. How long will they switch her around? A doctor's not going to keep switching you every month, every month, every month. Eventually they're going to find the one that you need and stop.
Sure.
Especially if it's a maintenance.
Correct.
Could you not, at that point, after you get something set something up for 90 days?
Well, we can do anything we want. Once again, it's just right. It's just the financial impact is one side of things. We're at a point now collecting third-party reimbursements that we're close to offsetting the expense of our medications. That's pretty uncommon, even in other tribal entities. They're not quite as efficient as what we are, because most all expensive 30 days.
But you'll eventually catch up with yourself. I've been in the retail business all my life. I buy low, sell high. When stuff starts slipping every 2 months, I may buy up 3 months, 6 months in advance when something's low. But I know it eventually pays for itself. It's a wash, is what I'm not understanding, I guess, from the monetary side of it.
As far as the money side, medications are they're continually increasing in price. The areas where we
Bingo, that's
save,
the reason to, right there.
you know, where we actually see our quote savings anymore is when we have generic conversions or transitions. You know, we have a brand new medication that converts to a generic. That offsets our expense or saves us money in that year, but you know, it's typically when they keep rising in cost, that it gets reabsorbed. So the patient population is rising as well. And there's several factors that create increases in our drug budget every year.
Could you prepare me some financials on this? I would really like to look at it. To me, it's just not making sense money-wise.
Sure. You know, we like to know what we spend and what our costs associated with medications are, what we collect.
Yeah, the whole 9 yards. Okay, thank you.
Okay, Counselor Garvin is next.
Thank you, Madam Chair. There's lots of big drug companies out there, Pfizer and Merck and others. Is there any particular one of those that we use mostly?
No, most of those make particular medications. There's not a one-stop shopping for
A company like Merck or Pfizer that do the whole 9 yards?
Not true.
No, really.
Which one do we use mostly?
You know, the one that probably has the most products in the market would be Pfizer. Not particularly our market, but just, you know, the nation as a whole. Pfizer and Merck are probably two of the bigger ones. Within our system, there's been a lot of generic transitions, so anymore we don't really use so many drug companies branding medications that we have in the past.
One follow-up question. Do we buy any drugs from any of the other tribes like Mohegans? They are in the business, aren't they?
Really, sale between tribes as far as medication goes.
Mohegans sell drugs, I understand.
Yeah, no, we don't purchase that. They still purchase their product from federal supply schedule, pricing structures as well. Some will purchase, once again, as I mentioned to Councilor Burns, we have smaller companies that purchase certain generics, and they buy them in bulk. You know, they may be short dated, something that won't last long on our shelves, and so they'll purchase that at their price and then resell for those who would use it quickly.
But those companies are in the business to make money, and we're going to try it everywhere
No.
to make money on us and everybody else. Okay, thank you.
Okay, has Mr. Valuers arrived yet?
Well, as he's coming up, can I ask for one last question?
Yes.
How were you at on consideration of compacting Claremore Indian Hospital's inpatient outpatient contract health service?
Where are we?
Is it willing to be considered?
It is under consideration because I think it would help us tremendously, but we just haven't done it yet, to be frank with you.
And next month, can you give us an ETA and if there's any business case analysis, provide that as it goes?
Yes, we certainly will.
Thank you, Madam Chair.
Thank you, Connie, for that good report. And as a quick note here, Councilor Lay and I and Councilor Meredith Fraley, we met with them up at Bartlesville last Monday with the Health Administration, and we had a very good meeting up there and learned a lot, and they have a great clinic. So I really enjoyed Councilor Lay inviting us up. Next, we have 4 items here that we need to amend the agenda to get. Oh, I'm sorry, I didn't see you. Oh, pardon me, I didn't see you back there, Mr. Valuers. I was taking advice from Councilor Hoskins. He didn't see you either.
He didn't want to be up here on Sunday lesson.
I'm about to the point where we need more time in health because I think it takes up 60% of the budget, and all 17 councilors like to speak, and we just can't cram it all in 1 hour. So I didn't mean to slight you in any way. Go right ahead.
My apologies for being tardy today. We've been without a chief nurse exec for about a year. We hired one last this last month. She comes to us from the Alaska Native Medical Center up in Alaska. Brings a wealth of information and knowledge to the table for us. Her name's Kathy Hilburn. I will try to round her up and bring her down here with me next month so you guys can meet her. Our orthopedic surgeon is already seeing patients. That's going smooth. Collections are up. We've already topped 15 million for the year, which is a milestone for us at Claremont. Any questions?
Thank you for that great report.
Well, now I have one question, sorry. Not getting off that easy. So from your staff's perspective, is everything going well under the contract health service compact monies for Cherokee citizens? And the report we get seems to be, is there any issues we need to work through or?
Not from our standpoint, it's working great because all we do is provide the technical assistance so that his staff does all the work.
Is there a chance that this could potentially impact IHS monies for contract health service? Can we need to turn the at all? Has there been any scuttlebutt back?
I don't see that happening.
Very good. Very good. Yay. Thank you, George. I appreciate it. Thank you, Madam Chair.
Okay, we've got 4 items here that we need to amend the agenda. Attend to them today. Have a motion to amend and then motion to second. We need to vote. Then we would like to amend the agenda. Vote.
Point of order. What are the items for the record?
For the record, they are, I'll put it shortly here as quickly as I can. We're short some board members for the Comprehensive Care Agency, and it's 2 board members to be appointed to 2 different boards. And we're very short-handed. It caught us in an emergency situation here where we don't have enough people to sign the checks, and we need to get it on the agenda. I think it's there in front of you. Everybody can look at it. All in favor of amending the agenda, let it be known by saying aye.
Aye.
All opposed? Okay, we'll amend the agenda to include these 4 items. Our first item of old business is discussion, comparison of healthcare provider salaries. This is sponsored by Councilor Fishenhawk.
We've started that health work group that we're looking at that in. And you know the book that you handed out to us on council here a while back?
Yes.
Could you, how can I say this? I looked at the book and I think in work group, I explained why I didn't want to listen to one section because it had an average of us in Talcott. Well, we're bringing the average down. So to me, that section was kind of useless.
Yes.
Anything that used the VA was kind of useless too because all VAs start out, all doctors' pays at $97,000, $98,000. So that part to me was kind of not necessary. Can you prepare something that has to do with more rural? Because I know there's a disparity in pay between rural and urban areas. If you go back east, big urban, the big city population, it's going to be different entirely from an urban area. Could you get some more, what would I call it?
The comparative rate for rural physicians is what you're looking for.
Yeah, not so much of the flat, and I'm not even looking for current. I want to be able to compare apples to apples.
Sure.
Where we're getting apples and oranges mixed up.
Okay.
Okay. Okay, thank you. Yeah, we'll just carry over.
The next
Carry over to next month.
Okay. The next is new business. Councilor Jordan, you want to?
Madam
Yes.
Was that a motion that needs a second?
I'll second. She made a motion.
Table the next month? Okay. All in favor of table the next month, say aye.
Aye.
All opposed? Okay, we'll table this comparative health study until next month when Ms. Davis can get us a little bit more information of a different kind. Discussion and possible action regarding the PACE Center and the Comprehensive Care Agency Board, sponsored by Category, Jordan.
I probably need to ask Connie a question about this. I think that putting these four on the agenda has accomplished half of what we're talking about here.
Yes.
So I just would like to table discussion and possible action regarding the pay center. We'll take off the second half. Okay, for next month. All right, thank you.
Okay, we need
I
a
make that
second.
form of a motion.
Okay, all in favor, say aye.
Aye.
All opposed? What, Councilor Watts?
Just to table, it wasn't clear, so I was waiting for it to be repeated, so we're tabling.
It was to table the first half, because the second half is going to be taken care of by what we just added onto the health agenda.
So the first half of the listed business item?
Discussion and possible action regarding the pay center.
Okay, so we're still doing the comprehensive care agency. Okay, thank you.
The next item is discussion and possible action of Health Department budget items. Councilor Dick Light and Jody Fisher-Hawk are sponsors.
Point of order, I think we need to,
Point of information.
I meant just to take that off because we added these four agenda items.
You're tabling all of item number one, not half of the first half of item
I'm
number one.
tabling half and taking the second half, just totally off the agenda because these four things will replace that problem.
Okay, thank you, Madam Chair.
Okay, Councilor Fisher-Hawk, Councilor Light.
Okay, discussion of the health department budget items. We was with Connie in a health work group, Dick and I, and Dick can talk to some of this, and we were talking about some capital expenditures, a master plan coming forward before the council before approval. As y'all remember, we used to have a master plan. Everything on there has been filled from last time except for the Sam hydrant. And they're wanting to come forward with a capital plan and a master plan. So we put this on here for discussion. What it is they're looking at clinics, they're looking at a surgery center, they're looking at buying some land. And what we're wanting to do is move a couple of county units and reserve them by appropriations where they have to come before the council before there's any expenditure. And Connie's here for any questions.
May I?
Yes.
I have asked the health department to bring forward that packet a couple of times, and I didn't see it in my mailbox, so.
Connie, it was the one, are you talking about the one that had the surgery center or hospital? Where is it? That's the one he asked that comes forward.
I guess the document you're referring to was just a list of discussion items. It was nothing official from the health department at all.
Yeah.
So no, I did not bring that with me today.
Hey, I've asked you a couple of times to distribute that to council. Have you received those emails?
I think I received one a few weeks ago. If you sent it today, I haven't seen all my emails today, so that may be part of it. Is there something on there I can answer for you?
Just a couple, a week or 10 days ago.
Yeah.
Councilor Watts?
Thank you, Madam Speaker. I don't know if the rest of the body may be aware of all the details behind where we're headed to, but is there some plan that we should have had in writing beforehand that we're referring to?
It wasn't an official document at all. There was some issues that I wanted to discuss with the chief that inadvertently got into the hands of this work group. It wasn't anything secret. It was just some things I wanted to talk to the chief about.
Internal work document.
Internal, yes.
Maybe something that wasn't.
Yes.
Good,
Thank
okay.
you.
So, but what I'm hearing is for this item on the agenda is now we want to fund something at the Sam Hyder Clinic, or we?
No, I think there were a couple of things on there that the surgery center is a topic of discussion that has been a work product or a project for at least 6 years that I'm aware of that the previous administration had worked on. to try and meet the backlog of surgery patients. Right now, there are 2,500 patients waiting for surgical procedures, and because of space issues, they can't be served. And so this was an effort that it's going to be funded through new market tax credits through CND to try and build a building to meet that need.
And it was with Tahlequah City Hospital or
It is with
something?
Tahlequah City Hospital. As a matter of fact, I think Brad Carson, back in when he was still here, spearheaded that effort.
So it doesn't even sound like it's something that comes in front of the council because it's a Cherokee Nation Businesses project on those tax credits that were already out there and projects they're doing.
It's a partnership, yes, but the health department will have to pay for the loan to build that.
And it's only in Tahlequah, but we were funding everything everywhere.
Well, that particular project was here, but just by chance, I've got some information that of those people waiting, about 300 a month come from the other districts, District 4, District 5. They're your constituents as well that are waiting for these procedures.
So Claremore Indian Hospital Service Unit area patients will have access to it.
Yes. Very good.
So when are we going to see details on this? Because I'm not seeing any details. It's a
But-
vague action.
And I have to apologize because I'm coming into this position assuming some of this information had already been communicated by the previous administration.
Well, we have council members, so it's always
That's
good to
true,
refresh.
that's true. So, I can get you that by email today if you like.
That would be excellent.
Okay?
I
And
don't
it
know
will
if
be
anybody else
coming.
needs anything,
Brian
but-
Hell has been working on that, and so I will have him send that. So if you get it from Brian Hill,
You have a number, it appears like you have a number of new staff members or staff members I'm not familiar with. Is there any change if the chair would allow that you could introduce the staff that are here? Because I don't know who a lot of these people are.
I only know a few of them. They're not on mine.
Okay, very good. Well, if they're
But I can introduce the ones I know.
Yeah, because I don't know anything about, people have been moved around and changed jobs and all sorts of stuff. People hired, and I don't know who anybody is anymore, so it'd be helpful.
Brian Hill is the CEO at Hastings Hospital now.
Hi, Brian.
He is a nurse, but he also has his master's from NSU, MBA.
Okay.
So he'll do a great job there.
And I assume he's a Cherokee citizen, right?
He is.
Okay.
We have all Cherokees on
I
this
hate to
staff.
assume anymore under this new, so.
Lisa Kovic. Does everyone know Lisa?
Yes.
Overseas. Everyone knows Brett, of course. And Jeff.
Unfortunately for Brett.
We know Dr. Nolan.
That's one you introduced.
Oh, Chuck. And you guys know Dr. Grant.
Okay, very good.
What do you
And the
call
health
it?
department.
Thank you very much.
Councilman Knight, you're next.
Thank you, Madam Chair. The proposed legislation that may come today does not have anything to do with the packet that we're all referring to. I thought it would be informational for the council. I've asked twice that it be sent to all of you. If we have 2,500 people backed up in the system for operations, is that what you're saying?
Yes.
Why don't we use some of that 5% contract health fund money to do that?
But because the majority of those patients are here in Tahlequah.
Doesn't matter. You need to read your legislation. Okay, the other thing, yeah, doesn't matter.
The policy's more restricted than the legislation, so it doesn't matter.
That's another thing. Policy, is it set in stone now? I've seen 2 or 3 versions of the policy of the 5% contract health fund.
I've only seen one.
I still don't know which one we're going by.
Restricted than the legislation, the policy does.
The one that,
Probably the last.
The last one?
Oh, doesn't make that hard for you.
The last one may be incorrect.
Yes, you do.
So we need, y'all probably need to look at it.
okay.
And like I said, this discussion of possible action today has to do with budgetary items. And the reason that I put it on is that it seems to me that some of these small budget numbers that that health has put into this budget, allow them then to take and run with any purchase, large purchase, large expenditures of money for equipment, land, building, anything you all want to do. It seems like to me that's what we've got here. And we want to put some restrictions on that so that you can come back to council and explain to us what you're doing, what you want to build, and go forward that way, rather than just have kind of like a Trojan horse in the budget. And that's where I'm coming from. And this fishing hawk, I think, has some of the final details. I yield to you.
What it is when we was in the work group, we looked at some plans that was coming up, and one of them was backdated from March of 2015 back to September of this year to start on the surgery center. It alarmed some of us there. David Thornton was there. We were there. Janelle was there. Doug Evans was there in this meeting talking to them about health. We expressed concern that there's so many clinics out there right now that are not having their doctors or their dentists or their health providers filled. That we're wanting to build a surgery center and a new clinic and start all this when we can't take care of what's on our plate now. We felt like that they was getting ahead of the problem, so what we wanted to do was make it where they have to come to council before they start any of these capital expenditures of buying land for X amount, building a surgery center, or hospital, or anything else. That's it in a nutshell. They just want to make it and put it, the money into a reserve by appropriations line item, which is the only accounting you can put something in that the council has to approve before it's spent. And that's it in a nutshell.
Councilor Frey.
Jody, was that the address, was that part of your overall long-range plan that you pulled this information from?
We asked her to please do like Melissa Gower did in the past and come up with a master plan, because when they started talking about the Telecom Center, first thing Doug Evans said is they talked about third-party revenues. Doug said, we can't pledge no more third-party revenues, we're at the max. They said something about bonds. He said we had to buy up to investment grade, if you remember on the last one, and since then we have been downgraded, so there's no doing that. So then they was back to square one saying, okay, how are we going to build this? So I felt like maybe that they was getting ahead of the money and looking at the ideal, especially after I talked to Doug. So I thought it would be wise to put it in an account and restrict it until they had a master plan and a long-term goal instead of just hitting this, that, and the other. Because we've got 2 clinics and they're suffering right now. And we didn't feel like we needed to go out there and open anything else and steal from any more doctors. And we certainly are not. We was wondering, how are you going to get the doctors to fill these spaces when we can't even get the ones we need now? We're like 36 doctors short. And when I multiplied it out by seeing 20 patients a day, we was up to 160,000 slots a year that we're short because we're short on doctors. But that's what it amounted to. There's no master plan right now.
And my intentions, I'm glad you brought that up, Jody, is that we will have a formalized master plan to present at next month's health committee. And I'm hoping with the work group's input and then our visits with the different clinics, we're hearing what the needs are, and we can get a good plan going forward.
Speaker Jordan, you're next.
Connie, are you in the next month, is there any thought of spending any money out of these 2 line items?
I believe the line items there was a $1.25 million that we had to come up with up front to do the surgery center. And there was a pressing need to get an approval or a blessing over that, if you will, because we have till the end of the year to use the new market tax credits that CMB has secured for us at a very good rate. So that was kind of the pressing need to follow up on that, not to mention meeting a patient demand. The other was land acquisition. And literally at the very last moment, 2 opportunities came up to build. There's a local office space that's available that we thought might be helpful to offset some of the patient load at Hastings and move some medical offices or do something with the property. We don't know that we're going to buy it. We've had realty go in even since the budget hearings and go and, we don't know that we're not going to pay what they're asking for it if we purchase it.
Are you going to do either one of those things this month before you come back with your comprehensive plan?
No.
So there's nothing going to happen in line items 3329.025 and 3329050 in the next month. You're giving this body that assurance.
Yeah, absolutely.
And you're going to come back next month with a comprehensive long-range plan that tells us where you want to place clinics and when we're going to place them and how long it's going to take to build them and what their cost would be and what maybe you're going to do at Hastings. You'll have all that to give out to this committee.
Yes.
I would suggest to the sponsors that since we don't have a written resolution to this effect, I would ask you to consider tabling for 1 month to let her come in with her comprehensive long-range plan. And before I make that motion, I want to throw that back to Mr. Lay.
And I appreciate that. And one of the things that concerned me about this is that it seemed to me it was slipped in without a lot of knowledge, without a lot of explanation. And I don't see how this body can stand for that. I mean, you can't slip something in and then run with it later and say, you guys approved it, don't you remember it says so right here. I'm going to go ahead and want to make this motion, and if it fails, it fails. But I'm at this point, I'm very hesitant to trust the health department.
I would go ahead and put that in the form of a motion, and with all respect to Mr. Lay, I would ask that we give her this month to get that long-range plan to us.
Okay, do we have a second?
Second.
Okay, motion has been made and seconded to table this for 1 month. And all of you in fact,
Do a roll call vote, please.
yes.
Will you please repeat the?
Well, okay. We need to have discussion. No.
No discussion on the table, but what's the motion again?
Just to table for 1 month.
Okay.
Okay. We'll have a roll call.
Chuck Hussing Jr.,
Yes.
Tana Glory Jordan,
Yes.
Lee Keener,
No.
Dick Lay,
Nope.
Curtis Snell,
No.
David Thornton,
No.
David Walkingstick,
Nope.
Kara Callan Watts,
No.
Buell England,
No.
Jack Baker,
Yes.
Joe Bird,
Yes.
Juliet Coates,
No.
Jody Fishenhoff,
No.
Meredith Fraley,
Yes.
Janelle Fulbright,
Yes.
Don Garvin,
No.
Frankie Hargis.
Yes.
Seven yes and 10 no.
Okay, it's not going to be tabled. Motion failed. So now we're back to the main motion.
Connie, it's nothing against you. When I walked into that meeting and I realized you all had backed up the surgery from March of 2015 to the start date of September of this month now, and none of us, when I started asking Dick, Janelle, David, anybody knew about it, and everybody was saying no. And when you handed out the paper and said you talked to the chief, it alarmed me, because that's a lot of money and the council knew nothing about it. So that's why I'm agreed and feel like it needs to be restricted, because the council needs to be in on it.
I understand. I sincerely do. It's a lot of money to tie up, and it's a surprise to everybody. But as I spoke with or mentioned earlier, I was under the assumption that a lot of the plans that I'm trying to pick up and follow through that I thought would be a benefit to the Cherokee citizens were things we should follow through on. There's a pressing need for the approval of the surgery center because of the time limit on the eligibility of the new market tax credits. And those were just discussion topics to see if the chief was still interested in doing that kind of thing or to move on. That was all that document was. And so here we are. So there's no effort. It was not intended to, the money to slip in. It's been in the budget in some format from the time I started talking to the people in finance for May. There was money set aside for a surgery center. And as a matter of fact, it was $2 million, and it's now down to 1.225 from what we thought we would need initially.
What happened to the other part? That's a good question. The $750,000. You said in May it was what?
There was actually 2 million set
And now it's down to
aside.
1.25.
It wasn't, we didn't need as much up front as we thought we were going to be.
Okay, so where'd you move it to?
But, oh, I would have to have Amy.
If I may interject, please, that may be a little bit of a misunderstanding. It was in a health M&I budget, and I think what health had done is they had internally said, this could be money that we could use for this project going forward. It had never had its own line item or anything like that. So, in rolling forward their budgets year to year, that was $2 million that they had.
In the maintenance improvement.
Yes.
And you took out maintenance improvement.
Well, I don't know if it was taken out of maintenance and improvement. If Amy Sam, is Amy Sam's here? She could probably explain what Connie's trying to say. This is a misunderstanding at this point, so Amy can probably clear this up. Okay. We're going to call her.
While we're waiting, just for enlightenment of the group, I did appoint a small work group of counselors, which was Counselor Byrd and Counselor Thornton, Counselor Lay, and Counselor Fishenhawk. And we also invited the deputy chief and the health administrators. And we met once, and the surgery center had been mentioned previously in the previous administration by Melissa Gower. So it wasn't really a shock to me, but I didn't know we were moving forward that quickly. But we are going to meet again on the 24th. And the whole purpose was to try to figure out exactly what is going on in health and try to get some work done to report back to the group as a whole, and also to try to shorten our meetings in here. But successfully, that hasn't been done yet. So we're running really behind. But this is very, very important because kind of like this is where the majority of our money's going, and Councilor Thornton can tell you that we really get the heat put on us from things that happen in the health clinics. And we're going through a tiring situation down at Redbird with half the clinic closed and everybody scrunched up, and not only do the patients get angry, but the people there in close proximity, everybody kind of gets on each other's nerves down there just a little bit. But you can imagine when you come in and close off half of your clinic and scrunch everybody up. So they're doing a remarkable job with what they've got to work with. But I don't mean to get off the subject, but I'm just trying to tell you that the health committee is really working. Jack Baker's next.
Excuse me, clarification. What are the two line item numbers that we're talking about?
3329, 025, and 3329, 050.
Thank you.
One of them's health plan building purchase on the health surgery.
My main understanding of that meeting and what I received from our CPA, Doug, and the thing that I really did stress is that the way I understood it, there's going to start this hospital here in the next month or two. It was supposed to be in 2015 just before the election. But the thing about it is, they didn't produce any engineering, any architects. There's schematics drawn up on this building. Where are we with that? That's going to cost you quite a bit of money just to do that. And $1 million, I'm going to tell you, isn't going to build that building. $2 million isn't going to build it. There's no funding on that building that will build it right now, and there's no architectural work done on that building that I could see. And we asked for it to be produced, and our CPA said, you can't start this thing. You don't know what it's going to cost. So to me, Mr. Lay is right down the alley. He's sitting there right. And we need to put a hold on this. There's other things that may pop up that we need to put a hold on until we look at it. But people, you can't build anything without an architect. And if you go if you go tearing stuff down, like let's take for instance our clinic. and you start moving walls in it, you better have an architect in there and an engineer to see what's going to happen to that roof when you go moving those walls around. But I've worked on pretty good sized buildings for schools when I was on the school board at Vian, and we did a lot of building there. And I'll tell you what, you don't start anything unless you have an architect right there, and you're going to find out what it's going to cost you. You're going to find out what your supplies are going to cost you, what your labor's going to cost you. And then to come back in and hire the employees for that facility, you're hiring employees for that facility, and you're not hiring employees for the clinics, which we need. And we need those doctor positions. They're staying 40 at that time. But that's the way I feel about it, and that's the way I'm going to be feeling about it, and that's what I'm going to vote on. Thank you, ma'am.
You want to comment?
As I said, that document was just discussion topics. What if, and how much it would cost. It was nothing official to present to anyone. And
Now, you're speaking of the hospital, right? Councilor Thornton, were you referring to the hospital?
Yes.
He's talking about a new
Yes.
hospital, and
Yeah.
she's talking about the surgery center.
Well, the surgery center. I didn't see anything on it.
there have been studies. Doug Evans has been
I
in
haven't seen
meetings.
archaeology. I haven't seen the study.
Councilor
I
Baker.
haven't seen anything.
Thank you, Madam Chair. It seems to me the appropriate, since the budget has not been approved, and it's on the agenda for tonight's council meeting, that tonight, when we're discussing the budget for approval, that these two line items should be moved to a restricted account at that time, and that would be the appropriate action to take. Thank you, Madam Chair.
Yes, Councilor Fisher.
That's what I said. They told me, well, it's best to be done in health, and I said, why can't we do it in the budget?
Okay, so we're going to do it tonight. Councilor Watts.
Thank you. I have a couple of things. I guess, I don't recall if we've had work groups formed outside before like that, but Madam Chair or any of the chairs, if we have work groups, I hope that they're noted in committee so that we understand up front who they are and what their purpose is, and then anything work product back, if they're a formal work committee like that, is reported out in committee so that all of us are aware of the results and stuff. And just going forward, I'd really appreciate that, because I wasn't aware that this was going on, and I don't recall us doing that in the past. Maybe we have, and I just misunderstood.
I thought that we discussed it in here, that I was going to appoint a work group. Maybe you were out of the room.
So
I don't know.
So I think, and I didn't necessarily need a response, just that, and I appreciate that it has been brought up, but this is the first I've heard of any work product and such, and if you're going to have other meetings, if we could have a
Well, I plan to
formalized-
give us an update on what we do if we do accomplish anything, rather than sit there and argue around about, except we're accomplishing something. But I'm just trying to keep it to a small group, and I left it up in Robert's Rules of Order that I had the authority to appoint a certain amount of counselors, and I did, and we moved forward with it.
Madam Chair, may I continue?
Yes.
Before, thank you. So I hope that we address those two. Since we have the budgets, the purse strings, constitutionally, it is in our authority that we address those issues tonight. I would ask that there be a solution between here and the full council for the Marcoma money too, because $1 million is going to be hard to find later if we don't address it. And I think that Connie and her team have brought forward some serious concerns around that. And I don't know that we would be wise in moving that away from the discretionary dollars and allocating it somewhere else and setting expectation in other programs and possibly impacting direct services as before healthcare, as well as the Marcoma facility and services there.
Well, I totally agree with you, because I think it would increase their paperwork so much out at Marcoma, but I just let everybody have their say and vote as they wish.
So, Madam Chair, will you be leading that charge to make a motion tonight then to address?
No, ma'am, I did not say that.
Okay, because it needs, I would think it needs to be addressed. Thank you, Madam Chair.
Okay, let's be clear here what we're doing. Councilor Fishenhoek and Councilor Lake, we are going to address this tonight and put a restrictive, is that what you're going to suggest that we do tonight? Put a restriction on those line items?
Let's just go ahead and do it in here, okay? I'll make a motion to move the line item expenditures on accounting unit 3329.25, 3329.050, which is the Talcott Surgery Center and the Health Land Building purchase, into a restricted by appropriations line item.
Second.
Okay, let's call vote.
Let's call for do it by acclamation.
Okay, acclamation.
Well, the question, but we need to state that this is to change the budget tonight. And whenever we have the budget brought up, the motion made for it, that it includes this motion. Just a clarification.
Okay. All in favor of putting this restriction on there, vote by saying aye.
Aye.
All opposed, same. Yes. Pass.
I know we're past the time, but if we're gonna do something on Marcoma, let's get her done now. So I make a motion that we amend the agenda to talk about Marcoma and where it's gonna come from in our budget.
Second.
All in favor of amending the agenda to discuss Marcoma property?
Aye.
Vote by saying aye. Aye.
Now I would like to turn it to Connie to tell us what we're gonna do. It needs to be, in my opinion, if I have the floor, it needs to be monitored or overseen by health.
Yes.
Now, how we get the money to it, that's another thing, but somebody needs to be in charge. And I think moving it under health was, our feeling was to put somebody in charge over Marcoma.
Health was, it was under health. It was just how it was funded.
Well, it needs to probably be managed a little bit differently.
Here's my understanding of it. When the decision was made to move the Marcoma Gym out of Gen Fund and IHS, along with that came some restrictions on the gym that will now we have to put into place. And so what I've asked Connie's group to do is to put together a summary, which I believe is in front of you, that shows you what the changes will have to be if it does in fact go under IHS, and what was it? What the proposed? Yeah, thank you. Okay, so what your current status is? Who's currently eligible for it? And then if you change it to IHS, who then will be eligible for it? And we had a pretty in-depth discussion about it. Dr. Grimm and Vicki Hanby, who I believe has left for another meeting, they were presenting some pretty interesting information that if this does in fact go under IHS, we're going to need to accomplish several things. And because I've not seen this before this meeting, Dr. Grimm, would you mind coming up here and telling us what those changes would be? I know that one is a resolution and a change to our compact. So I'll let Dr. Grimm address that with you.
Good afternoon, everybody.
Good afternoon.
Whenever the discussion began about moving the funding of the Recreation Center from Gen Fund to under Indian Health Service type funding, we were asked to put together a impact paper, if you will. And I'm just going to quickly hit the highlights of that, and then if you have any questions, we can go into them a little bit deeper. Indian Health Service has an open door policy. Essentially any American Indian or Alaska Native can be seen at any of our sites across the nation. Tribes follow that policy, so right now we are essentially restricting membership to some extent by the way we are charging people. So that's one issue. It would have to be full open door at no charge to all Indians, not just Cherokee citizens. And we do have a subset of other than Cherokee Indians that are coming to the gym and paying fees for it. To be allowed again to see these non-beneficiaries, two things have to happen. We have to have a tribal council resolution, and the law state, and it goes to Indian Health Service, and the resolution would state that we want to see non-beneficiaries there. And the law also states that what the council has to consider when they're doing that resolution is that we won't reduce services to the beneficiary population. And in this case, the beneficiary population would be all Indian clients of that facility. So essentially, because of that particular thing, that particular law, we would now not be able to see any of family members that are non-beneficiaries now or non-Indian from any of our employee bases, Cherokee Nation businesses, or from the government side of the house. The other issue is that that building that we're in right now is currently not compliant with the Americans with Disabilities Act. If it comes under a service that we're going to be paying for with federal funding, we would have to try to immediately start bringing it into compliance with the Americans with Disabilities Act. As was pointed out earlier, I believe, in some of the questioning that was done, because we can't charge Indian beneficiaries for that service, and at least initially we wouldn't be seeing any non-Indian beneficiaries or non-beneficiaries, we wouldn't have any charges. So we'd lose approximately $95,000 in revenue that we're currently receiving. And then there will be some audit requirements because it's falling under IHS funding. As they come and audit the funds that we do on our regular annual audit, they could potentially look at the eligibility and other requirements that we're allowing within that center. So the auditors could look at eligibility issues. So those are the, in a nutshell, those are the changes that would occur.
Okay, Councilor Fisher Knox.
Are you basically saying that we need to switch it out with third-party revenue?
Even if we do pay for it with third-party revenue, all those things would happen that I just mentioned.
Okay, talk to me about the ADA.
The American with Disabilities Act. I'm not as good as some of these other people about seeking out gym services there. So somebody that goes there on a regular basis can tell you what are some of the ADA requirements we'd have to meet.
Good afternoon. Currently, the building is not ADA compliant in that there are not ADA accessible restrooms. There is not an elevator for to go move between the first and second levels, and there are not doorways, automatic doorways for participants to come in. And that at one point, facilities have done an analysis of how much that would cost, and I have requested all of those documents from facilities. They have not been able to locate them yet, but it was an extensive amount of money, I remember, especially when you look into installing an elevator.
In a nutshell, what's your proposal?
My proposal, and I know that there's a lot of discussion right now about there being other gyms available for people to go to. When you look at the cost of other people using those gyms, we charge $30 for a family, no matter how many you have in a family. The one other gym I know of charges $100 per person per month. The other gym, I believe, is $40 for a couple, maybe more. So the non-beneficiary, non-Indian family or spouses or family members of our employees would not be able to be seen if we do use IHS funding for this. My proposal is that we find a way to fund it out of gym fund. Again, as we look into it more, because as it stands right now, October 1, there'll be no way that we'll be ready by October 1 to not see. We will have to see only beneficiaries October 1. And also, I would like to state that we've been talking about the space cost extensively internally and revising that, and we have requested that that be revised. If most of you look at that budget, you will see that roughly half of that budget is space cost and indirect cost, almost $400,000.
Have you talked to them about the space cost?
We have asked them to look at that and revisit it, and the last communication I had was that the
square footage that was being charged office space rent will now be charged warehouse space rent, which is $10 less. So they need to refigure all of that. But that should cut space cost in at least half.
200,000 roughly?
Roughly. I think it's going to be less than 200,000. My calculations were it would be around 100,000 total.
So we're looking at 791 roughly after
Roughly.
space cost is reduced.
And we're projected to collect 95,000 this year.
So we're looking at 681, if you take the 100 off and then the 91 off, then you have 680. Chad, do you remember how much was left on the table that we didn't appropriate during budget?
I don't have that.
I don't have, I never know what.
I don't believe there's anybody.
I don't think it was any.
Question.
Hey, Lisa, on the, you talked about the handicap accessibility. There's a bottom floor, an exit door on the back end there. Is there any way we could use that for handicap accessibility?
You know, we do right now. We do have
Is that how we do it right now?
parking on that end for people to access that door. Now, I'm not, you would have to speak, I'd have to talk to George Long or someone that's very familiar with ADA compliance, because I'm under the understanding that an elevator is what is necessary. But
Yeah.
I would have to revisit that.
And then you talked about the restrooms.
Restrooms need to be reconstructed.
Yeah, I think we probably need to put some type of hold on this, because we don't have all our numbers in order as far as what the costs are going to be to renovate this facility. And there's also some other factors that are playing into this as far as serving our non-beneficiaries. I know there's students from NSU that come over and use the facility, and I think October 1st is pushing it. And so,
And Northeastern State University has approached me. They plan to close their fitness center in the end of the fall semester for renovations in the spring, and have requested a meeting to see if we could accommodate some of their participants. Going to be, there's whole another group of people.
Increase funding.
Well, it's going to be.
I'm next, but you have it.
Well, I'm done. All right, thank you.
Connie, Lisa, don't sit down.
Okay, I'm not going.
Connie, what kind of gen fund dollars does health have?
Oh, I don't know. I'd have to defer to Lacey at this point because the budget has been.
Well, see if you can find 681,000 of gen fund tribal dollars that's going to health right now. We'll waylay it to pay for this, leave it as it's operating now, then we'll see about giving you your dollars back at carryover time. That would be my proposal.
Might work, Lacey?
I don't know. Yeah.
Connie, that makes the most sense, because we cannot meet the October deadline. Really, the way it's set up by the non-Indian spouses, it's worked well. I go there every morning, and it's okay. The numbers are good, but if we take overcrowdedness by Northeastern, any other facility, it's not going to work. It's not going to happen. So-
I agree. And back to me.
Yes.
And we can't build an issue of new fitness.
No, absolutely. No.
So if we're going to do anything, it's going to be for us.
Right.
Now, we might market our service to them.
Yes, we do, and we do currently try to meet their gym fees for students.
What we need to know is if you've got gym fund dollars that we can take from you with the anticipation that we can maybe give it back at carryover time. Make this work. If we don't have any money left on the table, we've got to find some money. And if you want to leave it the same, so you can still charge, you don't have to be ADA compliant, all those things that you just discussed, then we've got to find some dollars to continue the operation. And you're it.
Will that work, Connie?
Well, if they got it. If they got it.
Find that money?
What else you got?
We have the 1.9 million back to work for the program, and then we have revenue money from Davis for CHS.
And the
For
what's
what?
5% donation funds for CHS.
That one did that.
Those are our essentially tribal fund accounts. They're basically all CHS type accounts.
I would propose that we take the money from the back to work and then replenish back to work in our carryover funds when they come up in earlier, I think, Lacey, than they've ever been anticipated before.
Earlier than they've been anticipated for.
We never got them before until like March or April. We're gonna need them, you're gonna have to figure out how to get them to us quicker.
I can't guarantee that.
But you'll work hard towards doing it.
If that's the answer that you'll take, then that's my answer.
That's a good
I
answer.
mean, we can't establish carryover until the audit. I mean, that's the rule. That's the rule we're going to stick with.
I'm thinking though, if Connie and Chuck, if all of y'all work together, we can limp along until we get that carryover and make it and not see a decrease in services. Because we're not talking about for the whole year. We're talking about maybe a 4 or 5 month period. So we use up and then we replenish. We load your account again. Because we certainly do not want back to work to diminish in any way. That's too important a project. But I believe we can get there and give your money back to you. And I would ask this body to work with us on this, because if there's no money on the table, then this is a service that's serving thousands of people. And they're not just here, they're all over. And many of them are our employees. We need to continue that service. So I would put that in the form of a motion.
Second.
Up for discussion. Councilor Watts?
Thank you, Madam Chair. I appreciate prevention services and absolutely support them. But it's only primarily provided here in Cherokee County, and at the risk of jeopardizing back to work contract health services, I think is just not something that I can make today. If we need to go back into budget hearings even, I'd be willing to do that, and we could do a carryover resolution or something tonight. But this $1 million is hard to just, or 800,000, you know, we don't have a printing press in the back. We can't create our own monies. And to jeopardize such a critical program that really changes people's lives and impacts their ability to work and possibly get on social services and create a cycle for them and their family, we cannot put that at risk. And I would urge other council people not to consider it for that reason. Not because Marcoma is not important, but this is a more pressing matter. Thank you, Madam Chair.
I don't see a jeopardy of the back to work program. The back to work program is going to continue. We need approximately $700,000 to carry forth with another program that is also part of health, and that's keeping people healthy so they don't need our services. Folks, we're not taking away from one that won't get it back. We've always taken care of the back to work program. I would implore you to put this money into this program, and let's go forth with the budget tonight. I am 100% against passing anything just to run for another month. We've got a budget. We need to tweak it just a little bit. I put it in the form of a motion, and I would ask you to work with us on this one item.
Councilor Baker?
Would you consider transferring only $400,000 and then replenishing the amount needed at carryover for Marcoma, as well as the other $400,000?
Would you throw it to me and I'll ask
As a
one question?
friendly amendment?
Let me ask one question before I make a, will 400,000 keep us going probably till carryover?
Keep us going about 6 months.
Okay. I would accept that amendment.
Okay.
Is your second accepted?
So just to clarify, the motion we're about to vote on, it's 400,000, and before the 6 month mark, or what is the actual time frame trigger that it must be replenished to the contract health back to work, or is that what it's saying?
This one's going to need more money. before back to work needs more money.
But it looks like both need to be resolved, and that the motion needs to be very specific with a time frame trigger for me to support it.
Yes.
My understanding is the trigger date for the replenishment is carryover. Historically, carryover is approximately March or April of the year.
March
Not a,
21st.
so that's the trigger date in which we will replenish. I mean, it's the time frame. Could I ask the speaker if I had that correct?
Yes, at that timeline, we would need 400,000 to go into Marcoma and 400,000 to go back to work. And I would make that part of the motion, that be the first 800,000 that comes out of carryover.
That's 7 months. We need to add a little more because it's 50%.
I think we can probably make it with these figures. Yeah.
Are you agreeable?
I think we can make it.
Councilman Byrd, you're the second. You have another question?
Yes, and this is to Lacey. Okay, there were a lot of commitments. There's this commitment now, and there's commitments from budget hearing, but even though they were maybe not memorialized, things were said about, we're gonna wait till carryover. So if your team can capture all these foreseen commitments and how big this is before Chief Baker thinks he's got money for something else, I would appreciate that, because it looks like a train wreck waiting to happen in my mind.
Well, it's not. We've got that compiled, and we'll add this to the list. Right now, when I talked about carryover uses that will need to be addressed whenever carryover is established, is approximately about $2.5 million, say roughly in there. And there's also an amount on top of that to be determined what management resources needs for, their capital improvements, around here. So I'm not talking about, building a building, but I'm talking about improving our existing assets, what they're going to need. And so when carryover is established, we'll fund the programs that we talked about during the budget hearings. If management resources need some more money to fix up our capital assets here, obviously we'll just add this to the list. And so with that said, we're probably sitting about 3.3, about $4 million, somewhere right in there is what our carryover obligations, I guess I would say, sits about. And as far as being able to fund that, I don't think that's going to be a problem. Our dividend's been outperforming, and we're doing pretty well. So, thank you. You're welcome.
Do you have any other thing up for discussion? If not, I've got something to say about it. Before we vote. Sorry. It seems Marcoma is a wonderful thing, and it is well responded to. Thousands of people go there. But we are down there in the stepchild land of Sequoyah County, and people up north. Everybody would love to have something similar to Marcoma. We could all find an empty building that we could put the stuff in if we had a little bit of funding. So I urge this council in the next few years to consider expanding this, because we get calls all the time for people. They have relatives up here, and they know it's all centered around telephone. We want it spread out. That's all I have to say about it. I do support the gym, but I want the concept to spread. Yes, sir?
Lisa, with what you said about the expanding, we have a lot of grants, health grants that we get. Is there any way, I know schools get a lot of the grants, is there some way that we can get or consume some of those grants and do something like this into the communities like Adair County and Delaware and Sequoyah and Rogers and everything, and get facilities? Because that is a big complaint, especially people that work at Marcoma. They come in from way off and they say, well, it'd be nice if we had something at home.
We've talked about this extensively over time. Most of the grants that we receive, we've written for our federal funding, and they're restricted. There's absolutely no building, and equipment is restricted. Most of them are limited in the service and scope of what we're able to provide. Now, that doesn't mean that we can't go looking for more, probably more like foundation grants. But I know that for the last 5-6 years, when I've been asked this question by administration, I've always said that one of the things that we definitely need to invest in is infrastructure in our communities, because they all need it. I hear it repeatedly every day. got schools, community buildings, they need places to exercise, places to recreate with their families. So we can certainly look into it. I just don't want you to get your expectations to the point that you think it's going to happen quickly, because those funds are few and far between for facility construction and facility maintenance, and then you also have to consider who's going to take responsibility for that if we don't in a community.
Yeah.
I mean, it's possible.
Okay, I had to call for the question.
Councilor Wise?
Thank you, Madam Chairwoman.
It's been 2 hours.
I think you had an excellent point, and one that we have echoed before. So what we've tried to do is we've tried working within your Healthy Nation grants and stuff to partner with like Owasso's YMCA, Claremore's Rec Center. And I know that we're more fortunate in some communities that we do have those somewhat public facilities. But it is not something that we should do with our general assistance money and take away from those kind of projects. This should be within the health budget that you should negotiate with whatever those existing agencies are while you're still looking for grants for facilities, that we should, in partnership, write a check. If we're going to take $800,000 of discretionary money for Tahlequah, then we should go write a check to some of these other facilities and say, here is the deal you'll offer, which is the same as what we offer to Tahlequah folks for our Cherokee citizens and their families. There's no reason why we shouldn't do that, and I think that we should have a plan 2 months from now to that effect, if not next month. Because this has been on the table for a while, and it would increase all the work your staff already does. And there's been negotiations, but it hasn't got anywhere because we don't have the same support financially that is right here in Cherokee County. Thank you, Madam Chairwoman. I appreciate your ideas.
It's Tahlequah-centric.
Okay, we've got a call for the question. We have any more discussion? Okay. All those in favor of Councilor Jordan, you want to repeat it one more time?
I believe we were going to take $400,000 from the gen fund back to work dollars until
March 31st.
March 31st, and then we were going to replenish it with carryover so that there would be no diminishment in our back to work program. Then we were also going to add another $400,000 into this program, and that would be my motion.
Got a second.
All right. He seconds it. All in favor? Aye.
Aye.
All opposed?
Aye.
We need a roll call.
There's two legal here.
Who were the three that voted no?
Lee, Kara.
Lee, Kara. Four. Julia, Kara, Bill, and Lee. Okay, motion carried. So we're going to take the $400,000 out, replenish it March 31st.
With $400,000
Of carryover. Okay. Now, does that include everything on here? We voted on those health board members. Oh, we still need, no, we've already, we've already amended the agenda to do that. Okay, we've got 4 health committee items here. A resolution confirming the nomination of Deborah Proctor as the governing board member of the Cherokee Nation Comprehensive Care Agency PACE. A resolution confirming the nomination of Deborah Proctor as the governing board member of the Cherokee Nation Home Health Services Incorporated. A resolution confirming the nomination of Connie Davis as the governing board member of the Cherokee Nation Home Health Services Incorporated. A resolution confirming the nomination of Connie Davis, governing board member of the Cherokee Nation Comprehensive Care Agency PACE. We have a motion.
Motion.
A second. To improve in Toto.
So this was all four, the motions
All
for
four
all
together.
four? I have a couple of questions. I know Connie Davis has stated that she's a Cherokee Nation citizen. Is Debbie Proctor a
Yes.
Cherokee Nation citizen? Okay. And then it just says Cherokee, so I didn't know if it was United Kituaban versus Cherokee Nation. Has there been an attorney general opinion or our attorney look at the folks being on the board where they have to deliver and oversee themselves at the same time? Is there any consideration that we need to, that there may be a conflict of interest?
We've got a lady here from the Attorney General's office. She'll answer it for us.
I did look at the cases on this, and most of them, I looked at the cases on this, and I don't think there'll be an issue unless anyone finds a direct conflict of interest. If in fact there is, they could remove themselves if there's a question in the board. But they don't have any direct budgetary because it's a separate corporation, separate board. It's not direct.
Okay, and Elizabeth, I know everybody has good intentions, but I know I always need a refresher on conflict of interest stuff. We need to refresh them, or somebody refresh them on what they may need to recuse themselves from as examples and so forth, and what that standard is, just before we get into trouble, maybe.
Right now?
Not now, right now, but just before they really start. Yes, thank you. Elizabeth, thank you, Madam Chair.
Okay. I think we're ready to vote. How many?
Just going to
We're going to do it all. Yes, we need to amend the agenda for it to go into full council tonight. So we need to do that before we vote on it, or vote on it first.
Just as long as we know it's going to.
Okay, still go to full council after we vote. Okay. Next step is to vote on these all combined. And if you're in favor, say aye. Aye. Opposed? Okay, this all carried. Now we need to move it to full council tonight. Amend the agenda tonight, move it to full council.
Madam Chair, may I suggest that because health is becoming such a lengthy meeting because of the importance of the dollars that we have and the importance of the issues that we have, that we consider moving this to 10 o'clock on Monday morning and giving ourselves plenty of time?
That'd be fine with me. Hopefully, once we pass the budget, maybe it won't be as lengthy as next time, but we did have a lot of important issues here to cover, and we've got several people that might not can make it at 10 o'clock, so let's let everybody have their piece. Say what you please.
I would just, thank you, Madam Chairman. That means I leave at 7:30 in the morning for the house.
11?
11's better.
To 11.
Come on.
Let's go noon, and Madam Speaker, you can buy lunch for us.
As long as you guys don't come back on me later.
12 o'clock.
I got a suggestion.
Councilor Garvin?
Let's limit it to one meeting, not permanently, just one time, 12 o'clock.
Councilor Watts?
Can we not, because I noticed that on the food cost for the council that we really increased our food spending. So is there, and I know that there's other costs that would then be offset by that, but I mean, I thought it was very good to have 2 days of deliberations and have Monday afternoon and then Tuesday morning. Is there no consideration to go back to that?
Well, that's up to the council. I'm just expressing my opinion is no. Councilor Walton-Stick?
I have a suggestion is that we move the resource to the health time and then move the health to the resource. It starts at 4, then that'll be a 2-hour span to council to 6.
No.
Second.
Curtis says no. Curtis says no. Are you making that in the form of a motion?
No, it's a suggestion. I'm not, no.
I think the vote is before us. The question before us is next month, we're going to meet at 12.
Okay.
Let's see how that goes.
Yeah, let's try 12.
Oh, next month is Bull Hollow Fish Fry. Right?
Month after.
So,
You got to you have to give yourself enough time to get back from Bull Hollow for the rest of the meeting. So maybe we start this the month after.
all right, we'll discuss it again next month. Next month, we still meet at 1 o'clock because of Fish Fry at Bull Hollow. And if you haven't been up there and made the trip, it's well worth it. So, yes.
I needed as a guide last year, I still need one this year.
Second. All right, all in favor?
I don't know if you'll let us know.